of just their lack of consciousness or from the severity of the shaking. So don't be scared to throw a face mask on just so that they're getting some supplemental oxygen. Um, Now, circling back to the medications, one thing to keep in the back of your mind is that you need to know if this patient's being followed by an epileptologist or they're on continuous EEG, they may not want you to give medicines without them telling you to. They often will have, so like where I work, they often have an order in for medicine, so it's there in case of emergency. But they typically also have an order that says, do not give this medicine, call me first, and they'll have their phone number in. That way that they can, because they're typically on standby looking at these monitors, so that way they can look at it and say, okay, what is this? And then guide you on what to give. That situation in the ICU is fairly uncommon. That's more for the more stable patients who have known seizures, and it's kind of an anticipated thing. One thing I did not talk about was, I don't think it's on here, pardon me. Another way to diagnose seizures outside of EEG is grid placement. So whenever you have seizures that are coming from that, it's been very difficult to find their point of origination. Excuse me. Meaning that when they hook them up to EEG, they can't see exactly where it's coming from. And the seizures are severe enough, they may opt to do an implant called a grid, where a neurosurgeon goes in and lays electrodes directly on the surface of the brain so that they can see or try and see specifically where these seizures are coming from. And these are the patients, these patients typically, they have orders and not to give them drugs without being told because they want them to have a seizure. So, but these patients, because they're not on their meds, can begin to have very severe seizures and need to be very actively managed. So let's talk about some of the drugs real quick. Phenytoin, Dilantin, this is the one you're going to see very commonly. You can be given PO or IV. You need to check the blood levels to make sure that they're therapeutic. It's very easy to become toxic on this, and gee whiz. Hold on. It's a very common med you'll see, and it can cause gingival hyperplasia, so you need to make sure you check people's teeth and gums. There's also another form of phenytoin called Cerebix, which we use often, which is fosphenytoin. And I think by the book, one of the reasons that they use this med is that it breaks down quicker, it's more stable, and it doesn't, by the book, doesn't drop their blood pressure. But I can tell you that both this and phenytoin will drop your patient's blood pressure if you give it at a normal speed. And your patient's hypotension can last quite a long time, a couple hours. So whenever you're giving this med IV, you always need to check with your pharmacist about how fast to give it. So that's a very common med. One that you're going to see probably more in practice is Keppra. And this is becoming a more popular anti-seizure med. It's one that we use in our ICU. It's like our first line go-to. So Keppra is typically well tolerated. It typically does not affect your blood pressure too much. Now, one thing that they do not talk about, which you need to commit to memory, is that Keppra can cause mood disturbance, big time. It can cause suicidality in patients. So if you have a patient who started on Keppra, yeah, I'm skipping around between slides. If you have a patient who's on Keppra and they begin to become overtly depressed or anxious, or they just seem different, keep an eye on them. There are, every so often, you'll find a patient that just does not tolerate Keppra at all from that perspective. They'll get horribly depressed, very sad, very tearful. But the reason I'm telling you that is because you will come across Keppra. It's one we use in the hospital all the time. So I'm going to jump back up. The next drug I want to talk about is lorazepam Ativan, the A train. So this is a, I can't spell. This is a benzodiazepine. This is our emergency drug of choice. For patients having a seizure, we often have these on this. We have this on standby. It's a drug we can override. This is our go-to. Benzos are great for stopping seizures in emergencies. The bummer about it is that these patients can be altered for a long time afterwards, especially if they require a high dose to get them down. And Ativan sticks in the system for a little while. We'd like to try to avoid using this drug. I know traditionally, it's kind of a running joke about using Ativan because we use it for everything, agitation, seizures, all this stuff. But really, this drug is one that you really need to try to avoid unless it's absolutely necessary, especially in the delirious patient. But that's another talk for another time. Ativan for emergencies, a lot of times EMS will use diazepam. They may give it IM and they may give a hefty dose. So be conscious of patients coming in from the field for having seizures that not only might they be post-ictal, they may also be under the influence of a lot of drugs. And also keep in mind, if your patient requires too many medications to break a seizure, they may lose their airway. So they might need very close monitoring. Some other anti-seizure medicines that you'll see are carbamazepine. We often don't use that as a first-line agent. It's typically a third or a fourth-line agent. It doesn't have really any cognitive side effects. The only thing you need to know about the drug is that it can suppress your bone marrow, and it can have a skin rash. I personally have never seen the skin rash, but have seen bone marrow issues in this, as well as with Keppra, but it's very uncommon. Depakote and Depakine is one you'll see often, less sedating, less cognitive impairment. See this a lot in older folks. Typically not a first-line anti-epileptic that we use. Gabapentin by classification is an anti-seizure medication. You're most often going to see gabapentin given for things like neuropathy. Hold on, we got a question. We would give rectal diazepam once seizure was lasting over 2 minutes. Yeah, that makes sense. Also depends. Patients' care is often very tailored by epileptology. But Neurontin may be prescribed for seizures. I personally have never seen gabapentin be ordered for seizures, but that is by class what it's for. For side effects for gabapentin, dizziness, ataxia, somnolence, fatigue, and it doesn't say it here, but blurred or double vision is common. Lamotrigine or Lamictal, this medication, again, can help with seizures. I've seen this a few times used for seizures, but it's also used as a bipolar medication. With Lamictal, just keep in mind, there is a chance for Stevens-Johnson syndrome to develop. And what you'll find that, especially if you go into neuro or you work in epileptology, is that this is a very nuanced field, and how they guide their medication regimens is very, very tailored by the epileptologist. And there are, I want to say there's 3 or 4 generations of anti-seizure drugs currently, and we are rapidly moving away from a lot of the older ones that we used to use. Like I said, it's a very progressive field. Um, so I want to circle back and talk about the postictal phase really quick. Um, So like we said, that postictal phase is right after they've had a seizure, right? And they have this decreased level of consciousness, often confused, may not remember what's happened. But one thing that you should know is that the postictal phase can mimic a stroke. So there's something called Todd's paralysis, in which the patient has focal neurological deficits, meaning a very specific or unilateral neurological deficit in the post-ictal phase. And it can be kind of scary because, you'll see these patients and they may be like hemiplegic on one side for a little bit, which can often cause you to catch a ride to the CT scanner. But it is important to know, and even when we jump down to ischemic strokes, um, post-ictal phase or seizures is something we want to rule out as a stroke mimic. But um, what is the name again? Todd's paralysis. TODDS. I think there's two D's in it. One thing to remember as well is that, sorry, I'm jumping back and forth between the slides. One thing to remember as well is to ask the patient questions about their seizures if they have a known history of it. Ask them if they have an aura. Usually they know, like, to report, like, hey, I'm feeling like I think I'm going to have a seizure, or I'm going to have a seizure. If they have family at the bedside, when this is a common scenario that I see, is that mom or dad is usually at the bedside, and they'll call us in and say, they're doing this. This is usually what happens before they have a seizure. And that's very useful information because we can get ready. And some patients can very, very accurately describe when their seizures are about to occur. People who have seizures, who are epileptic, tend to have auras. Auras are kind of interesting. It's actually kind of, when you try to look up what an aura is specifically, it's kind of hard to get an answer. But an aura occurs when this abnormal electrical activity begins, and the patient typically senses it as some form of physical or psychic phenomena. They may, experience visual disturbances, changes in how they feel or how they talk. They may have a small, I've seen patients where, they develop some kind of tic, and they're like, well, I'm going to have a seizure soon, and that is the spread of that electrical activity occurring. Another thing that can be helpful is, and we talked about putting the patient on their side, things like that. One thing that is important is to try and look in their eyes. Their gaze position almost will tell you where typically where their seizure is coming from. And this is something that you can see in ischemic stroke as well as seizure, is that there are nerves, and there are nerves that control the direction in which your eyes move. And in strokes, they often get knocked out. So your eye's ability to stay midline is no more. So in one, they tend to look toward, and the other, they tend to look away. In seizures, they tend to look away. And you can think about it from as if the electricity that's building is pushing in the opposite direction. See, don't put anything in their mouth. We talked about the medications: rescue medication, Ativan, Keppra, and then therapeutic would be Dilantin. Nursing actions for women. Anti-seizure meds reducing contraceptive, medication effectiveness, pregnant women's fetus increased risk for defects, and increased hormones during menses pregnancy can increase seizures. That is true, but I've never seen it. Close monitoring of drug levels during pregnancy, may breastfeed, but frequent med level checks. So this is something that I do not have a lot of experience in, because hopefully most patients who are pregnant and have epilepsy are being closely monitored by their epileptologist. Um, but things to keep in mind. We talked about that. Status epilepticus, we'll run over this real quick. So this is an emergency. Oh, question. If Todd's paralysis is suspected when having, do you still call a code stroke and rule out stroke, or do you wait? So that's, so the question is, if you have Todd's paralysis, if you suspect Todd's paralysis, do you still call a code stroke? So the only situation in which we would suspect Todd's paralysis is if we have a witnessed seizure. If a patient's coming in from the field, and this is a little bit of a nuanced thing, but you're typically going to default to the worst thing. Now, if the patient's coming in from the field and they're having signs of a stroke with no seizure, we're going to rule out stroke. If a patient's had a seizure out in the field and they come in and they're having Todd's paralysis-like symptoms, we are more than likely still going to scan them just to make sure. Because every now and again, a stroke can present with a seizure. If a patient has a seizure out in the field, we still, especially if they don't return to baseline, are more than likely going to scan them to make sure there's not a blood or a tumor in their head. So as a general rule, you default to the worst thing, but you don't rule out other things. What would happen, right, is that a patient comes in with these focal symptoms, you scan them just to be sure, and then you see no signs of a stroke. So at which point you may do a CT angio, but if you still don't see any signs of a stroke, that's when you start thinking that maybe this is Todd's paralysis. But jumping over to status epilepticus, so this is something that is life-threatening. It says here it can last at least 20 to 30 minutes. Any seizure over 5 minutes, you can consider status. I've seen seizures break after 5 minutes. It's honestly kind of rare unless you have a patient with like known severe epilepsy. But if a patient's seizure lasts more than 5 minutes, you need to start thinking that status is coming. Now, these patients have a risk for hypoglycemia and acidosis because of this prolonged mechanical motion. You got to think that these patients are in full body, essentially full body convulsions, which burn a lot. They burn a lot of glucose. Your lactate tends to be very high, and these patients can get acidotic quickly, and often they're not breathing well. They may need a mechanical ventilator. If they go into status, they will need to be ventilated because you're going to have to go into what you call burst suppression, meaning that you're going to put them on a very sedating medication, often propofol, to make this stop, secure their airway, and hook them up to an EEG to see if it's going to continue. Now, this can be a long road for a patient. Oftentimes, the golden rule, don't make it worse and treat the underlying cause. We often are going to try and figure out what is driving these seizures. Now, like I said, this patient comes in, they're having this prolonged seizure. Oftentimes, because we can't break it with Ativan, we're going to probably paralyze and sedate them. Secure their airway, start them on propofol to burst suppress to stop all this brain activity, hopefully. Hook them up to EEG and confirm that. Now, when we hook them up to EEG, we can see exactly what we're doing to their brain, which is very helpful because we can see if they're still having breakthrough seizures. If they are, we're going to titrate our medication up until we see a quiet brain. And while we're doing that, we're going to begin other anti-epileptic drugs, typically Keppra and often Cerebix or phosphonitoin. And then after a day or so, we may try and titrate that back down, but we'll leave them on the EEG. That way we can see, even though they might be sedated, if they're going to start having seizures again, or Once they're awake, will they go back into status? Because that can happen. Now, if this is severe enough, we may need to put them in a barbiturate coma or pentabarb coma. Now, this is intense. This is kind of the end. I don't want to call it the end of the road, but we don't use barbiturate coma until we've typically tried to burst suppress them a few times. And because once they go into a barbiturate coma, we're going to leave them there for usually about 3 days. And oftentimes by that point, we've got them up to about somewhere between 3 and 5 anti-epileptic drugs. Now, one thing to remember to keep in the back of your mind is that typically every time you add an anti-epileptic drug over the third one, it has a decreasing chance, a substantially decreasing chance of not working. Or I guess it'd be a substantially increasing chance of not working. Meaning that if you have a patient who's gone up to 5 or 6 anti-epileptic drugs, they're in a bad way. Now, I've never seen someone pass away purely from status, but I've seen someone stay in the hospital, upwards of a month with seizures that could not be controlled and had to remain in some state of either burst suppression and or coma on multiple anti-epileptic drugs, and then develop secondary complications that they eventually passed from. We have a question. Is it appropriate to hang something with dextrose in this case since they're sedated and have burned through their glucose? Typically not. The correct response typically is to just stop it and let them correct. If a patient does become hypoglycemic, symptomatically hypoglycemic, it's going to be very difficult to tell. When a patient has a seizure, you're typically going to check a blood glucose anyway. And if they are having a seizure from hypoglycemia, then yes, give them dextrose. But if they develop hypoglycemia secondary to seizures, we need to just stop the seizures. Typically, those things resolve. If they do not, then in this case, you could hang dextrose, but it's not typically a go-to unless hypoglycemia was the cause of the seizures. Febrile seizures. So this is something that you're going to see in kids. If you see a febrile seizure in an adult, it's a bad sign. Fever does lower your seizure threshold, which is why you need to aggressively treat fever in adults and children. Febrile seizures often are not necessarily associated with a specific underlying disorder. They can just have a fever and just have a seizure. And then that seizure can go away once the fever is treated and not happen again. Rapid changes in temperature can cause this, but it can also cause a number of other things, including metabolic derangement. So if your patient is very febrile, you do want to be aggressive, but you don't want to drop them too fast. You're going to treat with acetaminophen or ibuprofen. And again, just going back to treat the fever, not the seizure, if it's from a febrile seizure. Of course, do your general care, make sure that they're safe, but you often don't need to start them on anti-epileptic drugs. Yeah, if you see a febrile seizure in an adult, their temperature is really, really high. It's probably at least 106. All right, any questions about seizures before we go to stroke? All right, jumping over to stroke. So we're going to talk about CVA. CVA is an umbrella term for different types of strokes. Strokes can be ischemic, strokes can be hemorrhagic, strokes can also be caused by, plaque buildup, so intracranial thrombosis, or an embolism. I'll question, is TI the same as ischemic stroke? Sort of. We're going to get there. So we are going to talk about TIA. So Stroke is a loss of function due to disrupted blood supply, right? So that can come from a buildup of plaque in the artery, so you can thrombose. You can also throw a clot downstream from your heart, which is a very common source, a cardioembolic stroke. Um, you can also have a hemorrhagic stroke. Now, I think that often there's a lot of confusion between what the difference between an ischemic stroke and a hemorrhagic stroke. A hemorrhagic stroke is an ischemic stroke, but the vessel ruptures. So you're typically still going to have ischemic infarct, but now there's also blood. Um, Here you can see a little CT scan of what appears to be a left MCA stroke. So speaking specifically to ischemic strokes, um, you can have large artery and you can have small artery. Small arteries are called lacunar strokes. Lacunar strokes, which is not what you're seeing in the scan, can happen over time. They can happen asymptomatically, and they can happen secondary to things like hypertension. The most common source of general ischemic stroke is cardiogenic. That's an embolic stroke, meaning that there's probably a thrombus or probably a blood clot sitting in the heart, secondary due to AFib. And then at some point it gets ejected and goes downstream. Now, your most common location for stroke is in the middle cerebral artery, that MCA. That's one of the biggest vessels. That's what you call a large vessel occlusion, but it is the most common cause. On the CT here, you can see where this red arrow is pointing to this darkened area within the left parietal lobe. This is more than likely a left MCA stroke, and you can see that this tissue is darkened. So this isn't a fresh stroke. This is probably 2 to 3 days out, depending on the severity of the patient. And you can see here within the bed of the infarct, there are some small signs of either this is maybe either the leftover tissue or a little bit of blood. So, pathophys. You have reduced or stopped blood flow, typically from a clot that fires off downstream, right? So, you don't really have any reserve in your brain to store oxygen or glucose. So once that clot fires off, your irreversible damage begins. Now I'm not going to get in like the nitty gritty of like your required blood perfusion per gram of brain tissue, but there is an actual like equation that you can look at, and this is something that like radiologists use to assess for things like the penumbra, but we're going to get there a little bit. Once a clot goes downstream, your irreversible damage begins. Typically when these patients, when this happens, these patients develop unilateral symptoms that are contralateral to the part of the brain affected. So you're going to have symptoms on one side of the brain or one side of the body that is often opposite to the brain hemisphere that this is occurring. We mentioned this yesterday when we were talking about the anatomy of the brain and how the signals decusate across. So if you have a right hemispheric stroke, you're going to have left-sided symptoms. Now, oftentimes these symptoms are dependent on where in the brain the stroke has occurred. So if you have a left, and let's say you have a left MCA stroke, you're dealing with part of the frontal lobe, you're dealing with most of the parietal lobe, and then you're dealing with part of the occipital lobe. So you're oftentimes going to see left-sided paralysis or paresthesia. So the side is either, or you're going to see a right-sided paralysis or paresthesia. So you're either going to see profound weakness of arm and leg or complete paralysis, not moving. You're often going to see deviation of the tongue. You're going to see a facial droop. You're going to see eye deviation and visual field loss. And this is in the most severe form. You can see any number of these symptoms, which is why we use a very thorough method for assessing what the patient's deficits are. We're going to circle back to that in a little bit. So when these patients exhibit overt signs of stroke, they will often activate a code stroke, or even a code IR if it's severe enough, meaning that they want to prep the interventional radiology team and neurosurgery to come in and be prepared to try and get this clot out. These patients come in from the field, they're often taken directly to CT. You want them to get in for intervention as soon as possible. When they say time is brain, it's not a hokey saying, it's true. The faster you can get this done, the better. And honestly, sometimes you'll see patients who make, miraculous recoveries, even though they've been, down for a while. You will see patients that had their symptoms identified immediately, and they got door to needle within an hour or less, and they get that clot out completely, and they still have irreversible, profound damage. So get them into the CT scanner. They're often going to do a CT, a general CT, to make sure there's not blood in their head that's causing this, make sure it's not a hemorrhagic stroke. They're going to do a CTA, so a CT angio, to look at the vessels in their head to clearly identify where the stroke location would be. And they're going to do a CTP, a CT perfusion. So they're going to look and see what part of the brain is infarcted and what part of the brain is penumbra. So penumbra is a term you're going to hear. This is a ischemic area that often is surrounding an infarct. This ischemic tissue is salvageable. So if you have a patient who has a small core infarct but has a large penumbra, we're often going to try to go after that clot because we want to save as much brain as we can. But if you see a patient who has a large core infarct and also a large penumbra around it, this patient is more than likely a high risk for bleeding, and they may not choose to go down that road. But that's for neurosurgery to decide. Now, while all this is happening, they're often going to be being worked up by a neurologist who's going to assess their appropriateness for something like TPA. TPA is this thrombolytic drug that we want to give them to try and break that clot up immediately. Some patients might not be candidates for it. Anyone who's had a recent bleed, recent head injury, there's a whole giant list of absolute contraindications, relative contraindications, and these things to consider that the neurologist has to go through. But if they want to decide quickly if that patient is a candidate, they may go so far as to, get this drug running in the ER, get them down to the CT scanner, and get them down into IR. If you get TPA, you can still get a groin puncture and go down to IR, but afterwards, you need to watch them very closely for signs of bleeding and or conversion. A question that was just asked is, what do they mean when they say a stroke blossoms? So blossom is a term you'll hear in relationship to strokes, in relationship to TBI, and it basically just means that typically blossoming occurs when it begins to bleed. When you see traumatic brain injury, you'll see brain contusions, and those contusions will often convert into these overt blood spots, and that's a blossoming of a TBI. Same thing with certain strokes. You can at times you can see what would be described as a weeping within the brain tissue, meaning that there is blood beginning to leak out into the space, and then that can blossom into a hemorrhage. It's a nice word for a bad thing. So TIA, let's talk about TIA real fast. So TIA is a transient ischemic attack. Typically, cell death, so true infarction, does not occur, but these patients are experiencing a stroke-like state that exhibits these symptoms that is going to come and go. If a patient has a TIA, that needs to be taken very seriously. Oftentimes, the patients who experience TIA are at a much higher risk for stroke. And patients who have recurrent TIAs, and I've seen this before where patients will have a few TIAs back to back, can progress to stroke quickly. So just because it's a TIA and technically no damage has happened, you should, especially because I've seen this, patients will be like, oh, I'm fine, I want to go home. You need to encourage them to get worked up because their chances of having a stroke are high. Um, ischemic stroke. So this is a little visualization of this thrombus getting in to the vessel, and it actually has a pretty good um, representation of the difference between infarction and penumbra. And one of the things I didn't talk to you about is collateral flow. So one thing, just like any other spot in the body's really good at compensating for things that aren't going well. So whenever you have this blockage of blood flow, while there is tissue infarction that almost will always occur, the brain tries to redirect blood flow, and everyone's brain can do that, better or worse than others. Like, it really depends on the person. Sometimes the patient's collaterals can keep them alive and complete and stop them from having any major symptoms from what's happened. But sometimes not, and you have a very large core infarction. So extent of infarction depends on time in the person. Blood vessel involved depends on more where the infarction occurs, right? We talked a little bit about those distributions and the symptoms that will come with them. The rate of the development of the occlusion. That is an important point, because if you have a patient who is having a stroke secondary to something like carotid stenosis, meaning that your carotids are hardening and becoming more narrow, the brain can compensate for a while, but once the occlusion gets so severe, you can start having these little mini strokes. And this is something you can pick up on MRI on certain patients, so you can tell that these have been occurring. But eventually, if it continues to progress, these patients will eventually more than likely have a stroke. And this can be unfortunate because you can actually occlude both your carotids. And I've seen people stroke both hemispheres in one hospital stay, their last hospital stay, rather. That's bad business. Now, things that occur slowly often times have better collateralization as your brain tries to compensate for that. But that doesn't mean that, especially in cases of, say, severe stenosis, that you can have a sudden and a catastrophic infarction. So risk factors for stroke, we have this split down to non-modifiable and modifiable. So our non-modifiable risk factors are, of course, age, gender, race. So age is above 55, male, African Americans. Modifiable. Now, I would say modifiable asterisk, meaning that things like hypertension can be modifiable, but sometimes might not, especially somebody who's got very severe primary hypertension from like a genetic source, say, and maybe they need, because I've seen this where I have young healthy people who are on 5 antihypertensive medications just because they have this awful hypertension. So sometimes it's not modifiable, but typically it is. Diabetes, smoking, hyperlipidemia, AFib is a big one. Carotid stenosis, but I would argue that once that occurs, that's not very modifiable. You're more looking at secondary prevention. Obesity, alcohol, and previous TIA. Hypertension, you can put like 15 stars next to big risk factor, along with AFib and diabetes. So stroke prevention, obviously trying to reduce modifiable risk factors, right? Smoking cessation, hypertension control, whether that be just improving medication compliance or regimen, weight loss, exercise, statins if needed, or any other way to get your cholesterol down, control your diabetes, get your blood glucose under control. AFib is a very complex topic, but if you're going to be on, how is AFib modifiable? So the question is, how is AFib modifiable? Because hopefully, and you can also argue that it might be a non-modifiable factor because maybe it occurred on its own, but we mean that from the point of like medication compliance, making sure that the patients are being compliant with their meds, making sure that they're therapeutic on their meds. That's a big one. Making sure that they're going to like their appointments at the coagulation clinic or wherever they go. And it says here, it talks about the idea of converting or versus anticoagulating. That's a pretty controversial topic. It depends a lot on the patient, on what started this, how it was caught. So for AFib, you want to focus more on, is this patient on meds? Are they taking their meds? Are they therapeutic? And are they making sure that they're going to all their appointments? And also antiplatelet drugs, i.e. aspirin. So we talked briefly about this already, but diagnostics for ischemic stroke, you're typically going to get a non-contrast CT straight away. Make sure you don't have any blood in your head. Get a CTA, CTP. MRI is going to happen, but typically not for a couple days. It says MRI next day is the most sensitive, but really that's going to be up to the decision of the neurologist. If you have a patient who maybe is experiencing severe cerebral edema, they might often wait to get an MRI. The purpose of the MRI is so that you can assess stroke burden. MRI is very sensitive to tissues so that they can look and see exactly what tissues are being impacted and how big the area extends. You're going to get an EKG, make sure you're not in AFib or any other odd rhythms. You're going to get an echo to make sure that you don't have any thrombus in your heart and you're not suffering from any overt heart disease. And you're going to get a carotid Doppler to make sure that you don't have profound stenosis or any other kind of issue in your neck that could be causing this, like a dissection. We talked about MRI safety yesterday. We're not going to get into that again. Here's another picture of a cerebral angiogram, and this looks like a left MCA. Now, left ICA with an MCA and ACA. So what you're seeing here, where this arrow is pointing, it looks like a partial occlusion. And so I'm not going to get super far down into this rabbit hole, but whenever you're doing a cerebral angiogram on somebody, you typically perform something called a Tiki score. So a Tiki score ranges from 0 to 3, 0, 1, 2A, 2B, 2C, and 3. And all that does is gauge the flow. Obviously, 0 is no flow, 3 is full flow. So whenever we assess that, whenever we're trying to assess the efficiency of a thrombectomy, so going in and sucking that clot out, you're going to gauge what your flow was before and what your flow is after. Now, I'm not sure where they are in this process here, but if this is an initial, right, this isn't a full flow. You do have some downstream, so you're not completely occluded, but this would not be a Tiki 3. But it's also not a Tiki 0, which is kind of a good sign. Now, when you look up towards the top of this picture, you can see where your anterior cerebral artery would be, and this outflowing side wing is your middle cerebral artery. And kind of in between, you can see a little bit of collateralization. And if you look like right here, you can see some little, some other vessels getting caught. So you can see some form of collateralization coming over here as well. Clinical manifestations, and we talked about this a little bit already, but that's going to depend on where in the brain you're hit. Now, like we said, most common place that you're going to get a stroke is in your middle cerebral artery. Your middle cerebral artery services part of your frontal lobe, part of like almost all your parietal lobe, part of your occipital lobe. And when you're looking at it from this view, you can see, and let's say it's on the left side, right? It's the left side. Let's just assume it's on the left side, not right, correct, left. That was super confusing. Left side, your speech centers. You can knock out your part of your frontal lobe, so your patient can have cognitive deficits. You're going to knock out potentially your eye fields, both from your damage to your occipital lobe, but also where some of your other eye field centers are. You often are going to knock out your speech, as you have your Broca's and you have your Wernicke's area. You can knock out sensory areas, meaning that your patient often may not be able to feel on one side or may have extreme neglect, and also motor, right? Here's your motor strip, so you can knock out arm and leg. So it all depends on where the stroke is and the vascular territory which it involves. So this is like a little diagram that you can have loss of vision, double vision, hemiparesis or hemiplegia, ataxia, which is more in cerebellar strokes. Dysarthria is very common, so the patient slurs their words. Dysphagia, they have difficulty swallowing, very common. And then they can have paresthesias, so sensory deficit on one side, and then proprioception, so an understanding of where a limb is in space. And you'll see it's very interesting because you can develop, a patient can develop very severe neglect on one side, and you'll say, move your left hand or squeeze me with your left hand, and they'll do nothing. And then if you pick their hand up and you put it in front of their eyes, sometimes they'll be able to move it when they're looking at it. When different areas of the brain get knocked out, it can be very interesting how that affects the patient. And you can even pick someone's hand up and put it in front of their face and say, is this your hand? And they'll say no, which is also interesting. So aphasia, I don't think we talked about this much yesterday. So aphasia comes in two flavors. It can be receptive or expressive, meaning that they can't understand or they can't express, or it can be global, meaning both. So when a patient has global aphasia, that is a nightmare. Just think of it as being trapped in a world where you do not understand anything that's being said to you, nor the context of anything that you're taking in. It is a living nightmare. Cognition can be impaired, memory, attention, judgment, then that can be from frontal lobe or just general stroke deficit from having a large stroke. And a big thing that we don't often talk about is the emotional impact of a stroke, and specifically the one having very labile emotions, either from damage to the brain or from depression, or severe depression after a stroke. So providers should have a fairly low threshold for starting antidepressants after a stroke, after you've gotten out of the acute phase of the stroke, if the patient is having severe issues with it. It's 8:45. Let's take a 10-minute break.
Okay.